Monotropic agent, dromotrope, vasodilators, vasoconstrictors, and diuretics. So all these here are cardiac drugs. Okay, so now cardiac drugs are classified according to how they affect the heart. Okay? Cardiac drugs affect one of or more of the following. The pump is the heart. We can give a drug that can cause the heart to beat faster. We can give a drug that can cause it to beat slower. We can give a drug that can cause it to beat more stronger. Or we can give a drug that can cause it not to be that strong. Okay? The vessel, yeah. We can control the condition of the vessel, the diameter of the blood vessel. We can give a drug that can constrict it. We can give a drug that can dilate it. And then the intravascular volume, okay, we can give fluid, we can take away fluid. Okay? And then we have to have normal electricity. And if the patient is having arrhythmias, we're going to give them like lidocaine or procainamide because we have to fix that for the heart to beat normally. So chronotrope is a drug that affects the rate of myocardial contractions. So you have positive and negative chronotrope. So any drug that increases the rate of myocardial contractions will be a positive chronotrope. A good example of that would be atropine. Atropine is a drug that we use to treat symptomatic bradycardia. Anytime somebody has a heart rate that is below 60 and is having symptoms with that, we'll give them atropine. And that will increase their heart rate. And then negative chronotrope will be like beta blockers. Beta blockers. You give a beta blocker, it will block the beta 1 receptor site, which would otherwise increase the heart rate. In that way, it slows down the heart rate. Okay? And then we have inotrope. An inotropic agent is a drug that increases the strength or decreases the strength of myocardial contractions. So a positive inotrope will increase the strength of myocardial contractions, like digoxin is the main one that you need to remember. Digoxin, dobutamine, vaccine. You may also call it Lemaxin. Lemaxin is the trade name and digoxin is the generic name. Okay? We can give dobutamine. That's inotropic. We can give dopamine. And then if we want to slow down the strength of myocardial contractions, we can also give beta blocker. A beta blocker is negative chronotropic agent as well as a negative inotropic agent. Okay. And that one I wrote down earlier, Norpes. And then we have dromotrope. A dromotrope is a drug that alters the rhythm for electrical conduction through the heart. Like lidocaine. Lidocaine is an antiarrhythmic agent. Now what happens is that when you have poor oxygenation status in the myocardium, or maybe you don't have enough electrolyte, you have electrolyte imbalance, you may have an area, okay, inside the heart that will start shooting out the electrical signals instead of the electrical signals coming from the ACL nodes. So when you give like lidocaine or procainamide, okay, it will go there and suppress that abnormal area that impulses are coming from. So that's basically what lidocaine does. Okay. Remember lidocaine and procainamide, they use those two a lot on the exam. If you want to give antiarrhythmic agent or they tell you that the patient is having PVCs, okay, those are usually the two that they like to use.
Can you write down the second one? I know lidocaine, but I don't recognize the second one.
I'm sorry, Dave.
Can you write down the second one? I know lidocaine, but not the other one you said.
Okay.
Just so I know the spelling.
Procainamide. Procainamide. They call it Nestil, procainamide.
Thank you.
MDLC loves these two drugs. All right. So now moving on. So now, positive inotropic agent. You gotta remember the Jackson. Okay, the Jackson, that's their model there. And now, sometimes if they don't say the Jackson, they will say the class that the Jackson belongs to. They may say digitalis. Somebody is having CHF, what would you give? Instead of saying the Jackson, then they will call it by the class, that digitalis. Okay. So another name for that group is cardiac glycoside. They may say that as well. In fact, they say that more than anything else. It's a cardiac glycoside or digitalis before they will even call it the Jackson, because everybody knows what it is. Okay. So digitalis group increases contractile force of the myocardium. And that drug is over 80% calcium. Okay, 80% calcium. Indicated for atrial flutter and atrial fibrillation. Okay. Now, when your heart is in atrial flutter or fibrillation, that would mean that cardiac output will go down because of the filling time. The filling time will be decreased. The chambers, don't fill up adequately with blood before it pumps because it's going very fast. So what we're trying to do there is to make sure that wherever the chamber gets filled up with will be pumped out. Most of it should be pumped out, just to increase cardiac output. So it increases cardiac output by increasing the strength. It increases urine output. If your blood pressure goes up, you make more urine, because now the kidneys will be more perfused. The more you perfuse the kidneys, the more urine you're going to make. The less you perfuse the kidneys, the less urine that you're going to make. Okay? If you have high blood pressure, you will pee a lot. If you have low blood pressure, you don't. All right, so side effects of the Jackson. Anorexia, and that's one of them. Visual disturbance, fatigue, digoxin toxicity. Okay, now digoxin doesn't clear from the body fast enough. Okay, if a patient is receiving digoxin, it is always a protocol to do AM blood work. AM blood work. Every morning the lab will come and draw blood, then they will check the level of digoxin, okay, in their blood, okay. I think if it is, I want to say greater than 2 nanogram per liter of blood, then that's too much. And the thing about it, though, is that when you have that digoxin toxicity, you can develop a rebound effect from that. And the rebound effect is like something causing the opposite of what you're giving it for. Like in this case now, we are giving the injection to increase cardiac output and blood pressure, but now you have toxicity, then it will decrease your cardiac output and your blood pressure. So that's what a rebound effect is. And then we have epinephrine. Epinephrine is a pressor. Well, it works in different ways because epinephrine can increase your heart rate. It can cause bronchodilation. It can increase the, decrease the size of the blood vessels, vasoconstrict the blood vessels. So 3 ways. So it's got an alpha effect, it's got a beta 1 effect, and it's got a beta 2 effect. Okay, so anytime you give epinephrine, you're producing those 3 effects. Okay? I remember a long time ago we used epinephrine for bronchodilation. If somebody needed a bronchodilator because of that reason, we give them epinephrine. Okay, but unfortunately, in doing that, you will cause unacceptable tachycardia and vasoconstriction. So when Abira and the rest of them and Zopiness came out, we backed off from the epinephrine. So you just now give it to increase the heart rate and increase contractility, all of that, but still that will cause bronchodilation. You all remember we use it for asystole. In fact, that's the drug that you use for asystole. When somebody has a systole, you do CPR, you give them epinephrine, CPR, epinephrine. You keep on doing that with the hope that they can convert to another rhythm. And then you start reading that rhythm. But now, if they don't convert, after 30 minutes, they still have a systole. That's the end of the resuscitative effort. All right, so beta 1 property increases cardiac output by increasing heart rate. Beta 2 property causes bronchodilation and vasodilation. Epinephrine is an ACLS drug, okay? Especially for VTAC, pulseless VTAC and VFib, okay? When you see that, the first thing that we do is we shock them, okay? We shock the patient. And then if the rhythm comes back, which is persistent, then the first drug that we give is epinephrine, okay? And then we shock the patient again, and then we start giving antiarrhythmic agent if the rhythm comes back. Okay, so normal dose is 1 milligram IV push. It can be instilled into the ET tube during the ACLS if IV side is unobtainable. Epinephrine and other drugs can be instilled down the ET tube. And you remember them with Nevo. Okay, Nevo is what you're going to use to remember all the drugs that can be instilled down the ET tube during ACLS. So,
Just went over it the other day, I already forgot.
these like this. This would be Narcan. Oh, Derek Nam, sign like that. So during ACLS, the doctor wants to administer Narcan, but there's no IV side. The rest of the therapy should pour it down the ET tube. This is atropine. This is was said. Also, you can give Valium. Diazepam. This is epinephrine, and this is lidocaine. Okay, so all these drugs here, we can instill down the ET tube. Usually, if you want to give any of them through the ET tube, you're going to double the dose, okay? You double the dose, and then you turn around, you rinse it down with about 10 milliliters of normal saline. So you got to trickle all the way down the ET tube into their lungs, okay? All these drugs here are absorbed from the lungs, So that's why we're gonna do it that way. Any questions? Isopretari now, it's still out there, but this drug has a very potent beta-1 effect. It can cause the heart rate to go up big time. Now, like I said before, the conventional treatment for bradycardia is atropine. But if you're giving atropine, but the atropine is not increasing the heart rate, then we give isoproterenol. Okay? Isoproterenol can cause your heart to demand more oxygen. Okay? It causes the heart to demand more oxygen. And if you're not providing adequate oxygen to the patient may end up having heart attack. So that's why we don't like to use it as the fourth choice. Okay? Another name for that is isoport. Okay. They have bradycardia. They're giving you that, you try atropine first. Okay? And you all know that you cannot give atropine when the blood pressure is high, right? Even though their heart rate is low, if their blood pressure is high, you don't give atropine. Okay? You only give atropine if they have bradycardia with low blood pressure. Okay? And here is the butamine. Okay? It's positive inotropic agent and chronotropic agent. It can increase your heart rate as well as increase the strength of myocardial contractions. It is a very good drug for patients that have CHF. Very good drug for patients that have CHF. It increases cardiac output without increasing oxygen demand. The antidote, the antagonist for that is propranolol, which is Indorol. That's a beta blocker. For some reason, you give too much of this medication and their heart rate or their blood pressure is going through the roof, then you give them Indorol, which is propranolol. Okay. So Indorol is both a negative chronotropic agent and a negative inotropic agent. And then we have dopamine. Dopamine is very common at the hospitals. It's just as common as Abira is to bronchodilators. It is positive inotropic agent. It increases cardiac output and blood pressure, increases cardiac output without increasing oxygen demand. And again, the antidote for that is Indorol. Okay? We've heard enough about this. Yeah, it's making me sick. Right? So we know what preload is. To increase preload, you give fluid. To decrease preload, you diurese. Okay? That's another one. Let me back up here for a minute. Now, how would I know that my preload is low? Which hemodynamic pressure would I look at? Is it my PAP, my CVP, or my waist pressure? Waist pressure, CVP. Remember, what you get on the right side is what you get out from the left. So if my CVP is low, my waist pressure will also be potentially low if I have hypovolemia. Yeah, because with hypovolemia, all the pressures are low. Okay? And then how would I know if I need to diurese the patient?
Everything's way up.
Hypovolemia, right? All the pressures will go up, especially CVP. So after load now, the resistance, we want to increase after load because somebody's blood pressure is low because their blood vessels are vasodilated, and then we're going to give a pressor. okay, or vasopressor, or vasoconstrictor, whatever you want to call it. Epinephrine is one of them. Vasopressin is another one. And then norepinephrine is the most potent vasopressor. Now, epinephrine is adrenaline. Vasopressin is, let me try to spell it. Vasopressin, somebody can Google that and make sure it's right. I think it's vasopressin, like that. And then norepinephrine is levofid, very common, levofid. Very potent vasoconstrictor. In fact, before the patient can go on levofid, they have tried everything else to try to increase their blood pressure. Okay? They may be at the dying stage, really, for hypertension. Because what happens is that when you give this, you constrict the blood vessels to the extent that you stress the heart. Now, because they're so constricted, now the heart will stress to try to get the blood out. Okay, so they use it, that's the last thing that they want to use. Okay? And then we have, if we want to decrease afterload, the resistance is high, like the SVR is high, then we're going to give a vasodilator to open up the blood vessel so that the blood pressure will go down. We can give nitroglycerin, okay, that's a vasodilator, nitrite, okay, or sometimes they call it the nitroprusside sodium. I like when they call it that on the exam. Nitroprusside sodium. We have nifedipine. Okay? Nifedipine is also called proconia. It's a vasodilator. In fact, there is some drug that if your mother comes in with Braxton Hicks having premature labor, they will inject them with nifedipine. Okay, it decreases contraction of the uterus. Okay, it's a vasodilator. And then there's isodil or isosorbide. The nitrate. If it's not one of these here, anything nitrate, nitrous, any kind of nitrate is a vasodilator. If it sounds like a nitrate to you, you pick it. Okay? Let's review here. Name a drug that increases afterload. Depressors, right? Epinephrine, dopamine, vasopressin. The vitamin will do it as well because it is a peripheral vasoconstrictor. The vitamin is a peripheral vasoconstrictor as well. Name a drug that decreases afterload. Nitroglycerin, right? Nitroglycerin, nitroprusside sodium. If you remember this one here, that should be good. That's what they like to use, nitroprusside sodium. And then if they want to be funny, they call it nitrite. You just remember that one. They don't even use nitroglycerin on the can, they use that one there. All right, how do you decrease preload? You diurese, right? You diurese. How do you increase preload? You give volume. Yeah, you give intravascular volume. Antiarrhythmic agents. Okay, Okay? Now, we have 3 groups here, and let me kind of just draw this. And let's review a little bit here. If you have a cardiac muscle cell, like that, you have electrolytes on the inside of the cell, and you have electrolytes on the outside of the cell. So these are called intracellular electrolytes, and these are called extracellular electrolytes. So now if you look closer, you have more potassium on the inside, about 145 maybe, milliequivalents per liter. Milliequivalents, like that, per liter. That's the unit for electrolytes. And then on the outside, you don't have enough electrolytes, about 5. Okay? Then on the outside, you have about 141 sodium. You have more sodium on the outside. On the inside, you have about 4 or something like that, or 5. On the outside, you have 5 calcium, and then on the inside, you have 1 calcium. So this is the way that electrolytes are distributed on the inside and outside of the cell. With that, you know, electrolytes are responsible for creating the electrical current in our body. So when we have this normal distribution, there is electricity being generated across the cell membrane. And what we call that is normal membrane potential. That's about negative 90 millivolts. So the cell is resting. There's no electrical current coming to it. You have that. But then, when the electrical current comes down from the SA node and strikes on the cell, then you have what we call changing membrane potential. That's what we call depolarization. Depolarization means now that sodium will rush into the cell. You have influx of sodium into the cell. You have exflux of potassium out of the cell. And then you have more calcium going into the cell. That's what the electrical current does to the cell. You have changing membrane potential. As a result of that, the membrane potential increases to +3. The cell becomes positively charged. Okay? Now, the end game to that of depolarization is to increase intracellular calcium. That's the end game. Intracellular calcium goes up because you have influx of calcium into the cell. And then those 2 muscle filaments are called the actin and the myosin. With increase in calcium, now they begin to rub together like that. Okay? That's how we get contraction. So, what the antiarrhythmic agent does is to slow that process down so that your heart is not going fast. Because if we can slow the sodium from going in, or maybe the calcium from going in, then we can slow down the heart rate. Okay? So that's what we're saying there, that drugs used to treat cardiac arrhythmias are classified into 4 groups according to their effect on the action potential, electrophysiology of the pacemaker and the myocardial cells. We have to block this chain reaction somewhere. We can block it. We'll slow down the heart rate. So you go to group 1 now. So group 1 antiarrhythmic agents work by preventing the influx of sodium into the cell. As if the sodium doesn't go in, these other ones will not go in. You will not have increase in intracellular calcium. Okay? And the only one that you really need to remember there is lidocaine, very common. Well, sometimes you may remember dilantin too. Dilantin, if the patient has grand mal seizure, you give them dilantin. Okay, grand mal seizure. Okay, so lidocaine, we use it for PVCs, premature ventricular contractions, ventricular tachycardia with or without pulse, and ventricular fibrillation. Okay, 4% of that drug is used as local anesthesia. Okay, numbing medication, 4% of it. Now, if somebody is going to go to bronchoscopy, a respiratory therapist will have to aerosolize 4% lidocaine. Okay, so what you're doing there is you're going to numb their cough reflex, you numb their gag reflex, you numb their tracheal reflex, and then you numb their laryngeal reflex, okay, acrinal reflex, 4 airway protective reflexes. So that when the doctor goes down with the bronchoscope, the patient doesn't cough all the time, they don't cough as much, they won't have laryngospasm like stridor, okay? The patient will not gag, things like that. So we do that. All right, so just remember dilantin, mainly grand mal seizures, okay? And then we go to group 2 antiarrhythmic agent. They control arrhythmia by blocking the beta-1 receptor side. If your heart is going very fast, we can block the beta-1 receptor side. Okay? Unfortunately, when you give a beta blocker, not only are you blocking the beta-1 receptor side, you are also blocking the beta-2 receptor side. Remember, the beta-2 causes bronchodilation and vasodilation. Now, when we block it, we're going to get a bronchoconstriction, okay, and vasoconstriction. So, some of the beta blockers are not very good for COPD patients. In fact, if you get a COPD patient that needs a beta blocker, okay, you have to really select one that will not block the beta-2 receptor side. Otherwise, they're going to whiz more or have more difficulty breathing in. Okay? So in the raw, these are the only 2 that they really want you to know, but you got to recognize the other ones. In the raw is also called propranolol. Propranolol. Okay? That's one thing I like about beta blockers. They're all ending law. Come here, Dr. O, law. Is that how you say it? Law. What does that mean?
Laughing out loud?
Law. Is that what it is? Because I hear people say it all the time. Law, go to vacation, law.
No, that is laughable.
No, seriously, what does that mean? Is it like...
Laugh out loud, so.
Is that what that means?
Uh-huh.
Oh, really? Well, I learned something today, law. The next thing that I love to say is bless your heart. Bless your heart. All right, so Inderal. So now Inderal has the ability to block the beta-2 receptor side. It causes bronchospasms, causes dyspnea and cough. So you may have to think twice before you give it to a COPD patient, because that will first stop that wheezing. And then we have low pressure. Okay, low pressure is metoprolol. It's a better drug for COPD patients than Inderal. It doesn't cause as much wheezing for them. Okay? Now, these are the ones that we also have to remember. Sometimes they may use it to write a question. Here's a patient that just arrived in the emergency room, that receiving tenomine or whatever. At least you know what they're talking about. Okay? So we have gravy block, osmolol, that's selective. So that one will only block the beta 1 receptor side. We have Citrol, Osumbutalol. A lot of people take that one there for hypertension. If your hypertension is being caused by your heart going very fast, then you're gonna, the doctor may put you on Citrol. Okay, as selective, it only blocks the beta 1 receptor side. And then we have the tenomine, which is a atenolol. That's also very common blood pressure medication. That is also selective. And then we have Normodine, which is lembetalol. Non-selective, that one will affect both beta 1 and beta 2 receptor side. We go to group 3. Well, the only one that you really need to remember is amiodarone. Okay, how did they say that? Corderone. I think this one is Corderone. It's ACLS drug. Remember, like you're treating positive VTAC or VFib, you're giving your epinephrine, and then you shock your patient, but the breathing comes back. It's time for you to give antiarrhythmic agent. Okay, so you have 3 choices. You have lidocaine, you have amiodarone, then you have magnesium sulfate. When should you give magnesium sulfate?
Torsades de points?
When they have the torsade, right? Yeah, you got 2 types of VFib here. You got this one here. They call it fine VFib. And then torsade is kind of like that. It's more coarse VFib. Okay, you give magnesium sulfate. But if you don't have torsade de points, don't worry about magnesium sulfate. Then you select from either lidocaine or amiodarone. You give one of those 2. And it doesn't matter which one that you give. Both of them will work fine. Okay? Now, amiodarone can cause pneumonitis. Pneumonitis is like inflammation inside the lungs, okay, as a result of the chemical. The drugs are chemicals. Every drug that we take is a chemical, okay? You have inflammation inside the lungs. Now we go to group 4. Now, group 4 drugs are those drugs that will prevent the influx of calcium into the cell. Just remember, we're trying to decrease contraction now. So that's why we call them calcium channel blockers. So it's going to block that channel that calcium is going to go through to get inside the cell. Okay? And then we have example there, those 3 there. Let's see if we can. Those 3 we have verapamil. That is been around. There are 2 brands that I know. Verapamil, you have the Coline, and then you have the Isotin. Okay? And then we have Puritanism, that's cardism. That's cardism. Very common on the Zen. That's common. And then Philippine is Procardia. Those are calcium channel blockers. They will slow down the heart rate by blocking the influx of calcium into the cell. Okay. Here's atropine. Okay. anticholinergic agent. Okay. It increases the activities of the ACA node. It causes the ACA node to fire at a faster rate. Okay. It's also a bronchodilator, if you don't forget that. Long time ago, we used atropine to provide bronchodilation, but unfortunately, anytime we give it to a patient, their heart rate rests. And then when the atrovent came out, we backed away from using atropine. But even up to today, if you give atropine to increase heart rate, you also cause a bronchodilation. Okay? It is a bronchodilation. And then we have epinephrine. Epinephrine can increase your heart rate because it affects the beta-1 receptor site. Okay, antithrombotic therapy. Okay. These are blood pressure medications as well. Anticoagulant. Now think about it now. If somebody has CHF, okay, but their blood is very thick, because your blood gets very thick when you have more cells in it. There's something called the hematocrit. This is where you compare the liquid portion of the blood and the cells. Okay? You're comparing it. It's supposed to be that the liquid has to be 55% and the cells would have to be 45%. Okay? Now, so what they do now is they draw blood, they put it, inside a test tube, a little bit of blood inside a test tube, and then they will centrifuge, they will spin it like that. And then they sit it, they put it aside to settle. Okay. If your cells are more than the liquid, then you have high hematocrit. It means that your blood is very thick. Well, if the liquid portion is way above the cells, then you are hydrated, overhydrated. So hematocrit can be used to measure dehydration. Okay? So now, if my blood is very thick and I have a weak heart, then it makes it very difficult for the heart to move it. It will stress the heart. So that's what you get. Some of the patients that have CHF will also be on blood thinner because we want to thin their blood, make it easier for their heart, for their weak heart to move it. Okay, so that's why it's cardiac drug. Okay, so we have antiplatelets. These are the ones that will prevent the clot from forming in the first place. Aspirin is in that group. Okay, maybe aspirin. And then we have thrombolytic agents. These are the ones that will actually break the clot. They will actually break the clot. We do that one last. Okay, if somebody has embolism, we do thromboembolism, we do that one last, because once you break that clot, it will follow the blood flow and will maybe end up where you don't want it to end up. It can end up in your brain, it will stroke you out. Okay? End up in your lung because it's pulmonary embolism. So first of all, our goal is to give them things like heparin to prevent the clot from getting bigger. Okay? All right. Oh no, let me talk about it some more. So they may say, well, let me think about the question here. There's one pertaining to that. Oh, it says like, X-ray has returned with the result peripheral wage infiltrate. X-ray has returned with the result peripheral wave-shaped infiltrate, which of the following drug to the respiratory therapies recommend? Well, peripheral wedge-shaped infiltrate will be infiltrate for pulmonary embolism, right? Yeah, pulmonary embolism. You have to be able to associate X-ray characteristics, okay, with the disease process. So it's just like pulmonary edema now. If you say a butterfly pattern or bat wing or you know, what's the other one? Flow-free infiltrate, you got pulmonary edema, right? If I say like cardiomegaly, I'm talking about enlarged heart, CHF. If I say a flattened diaphragm, widened intercostal spaces, small heart, I say, well, you got COPD. Okay, so we'll get to that when we start our review. Okay, so they may say, well, X-ray has returned with the result. What do they call pneumonia? They call pneumonia. What's the X-ray characteristic for pneumonia? Huh? Thank you, that's it. Air bronchogram, that's it. Air bronchogram is nothing bad. You have here's your normal alveolus. And because of all the fluid and pus and everything, in here, they look like that. Make it sag. That's air bronchogram. Okay? All right, let's keep on going here. Name one anticoagulant. Heparin, right? Okay. Name two beta blockers. At least, come on, at least the two that they want you to know. Indirol and metoprolol. Okay? All right, so that's a quick review of advanced pharmacology. Okay? Now, we're going to do our two clinical simulations, and I want us to do